currently supports about 30,000 health professionals that are committed to service to the underserved. Through the ARA funding, an additional $300 million was provided to the program, and will add about another 4,100 physicians, nurses, dentists, and other health professionals. So this expansion then will effectively double the number of National Health Service Corps clinicians in the field at this time. So the 30,000 clinicians was actually a historical figure. At any given day, now we've got about 4,000, and this program will double that. So we'll have about 8,000 at any given time. So in addition to that, the HRSA also supports other types of health professional training programs. About $200 million has been provided, an additional $200 million to help rebuild the professions training programs with an emphasis on nursing to build institutional capacity and support qualified students at colleges and universities. So in addition to workforce support and facilities support, the HRSA also has a number of small little demonstration programs, projects, and collaborations that go beyond simply managing grant programs and contracts to actually looking at what works, trying to identify what works in communities. An example would be the learning collaboratives that we've been involved with, and I've mentioned these in the past. And examples of the collaboratives that we've supported, we have a patient safety pharmacy collaborative currently with about 65 communities involved around the country, testing and developing quality ways for patients to get their med-med reconciliation, to make sure that there aren't handoff errors as patients are traveling through that system. And those systems include community health centers and HIV/AIDS centers and rural health clinics, but they also include community pharmacists, local hospital emergency rooms, other places where our patients go to make sure that they're being managed, that they're to reduce the possibility for error and improve the handoffs. We have collaboratives in the HIV/AIDS programs. We have organ transplant collaborative that increase the number of people who are able to have access to organ transplants. We have some health disparity collaboratives that we've provided support for over the years in diabetes, cardiovascular disease, perinatal, cancer, asthma, depression. So those programs are programs that where teams of clinicians from across the country pull together and learn together what works, what are the best practices, how to most effectively care for those patients, and they track outcome performance measures to know that they're moving in the right direction. There's a real emphasis on care, following clinical guidelines, and creating care pathways through those programs to make sure that patients are managed most appropriately. So those are just some small examples. We also currently, another example is we currently are working with a federal tobacco collaborative. So our partners are the FDA, Office of Women's Health, and our HHS, Office of Women's Health here in the Humphrey Building. And the program is to develop prevention and cessation services, provide tobacco cessation materials, and to provide regional and training and technical training for health center staff. That's our part of the project. And another example is a project that we have with the Center for Disease Control, and it's a TB hepatitis C health disparities elimination project. And that's a very small project, once again, but it's developing infrastructure and models of care to facilitate TB and hepatitis C screening, prevention, treatment strategies, and we work with in three states with selected health centers, and we collaborate with SAMHSA and the Center for Disease Control programs. So in summary, the HRSA programs represent a major health service and training infrastructure with HRSA-supported programs in every U.S. state and territory. HRSA community and HIV/AIDS health centers use sophisticated approaches to manage their patients to ensure adherence to clinical treatment guidelines for as many people as possible. And we work to enhance patient health outcomes, and that includes HRSA collaborating with others to develop model interventions that are based on adherence to guidelines and the evidence base. Also, of note, we have a new Chief Public Health Officer, Dr. Q. Ree, who has joined us at HRSA from the NIH Center for Minority Health and Health Disparities. He will be helping to articulate HRSA's public health interest, and he has an interest in community-based participatory research and comparative effectiveness research. So we'll have more on that in the future. So with that, I'll thank you and answer any questions that you might have.
Is there any questions? Len?
Thank you for talking about HRSA and its mission in terms of providing for the uninsured and vulnerable. Very important mission. And it's also refreshing to hear that there's over $2 billion that's been spent for access of care in 126 new health centers. It's also interesting that I understand the Ryan White Act with HIV and AIDS is something that has been extremely widely publicized, and your agency has a lot to do with that. And during your testimony, you also mentioned asthma, depression, tobacco, and hepatitis C, and very interesting programs for those areas. I was wondering, in the CFS area, is there anything that your agency could be doing or has been doing, or any way of us interacting with your agency, given that there's literally hundreds of millions of dollars for dealing with the exact same issues that our group is faced with literally hundreds of thousands of people who really don't get access to good care with CFS?
Well, thank you. I appreciate the question. I think the way to answer that is to explain how those health disparity collaboratives come about. The ones that I listed a number of disease areas that we focused on and with community health centers, and those particular focus areas came up to our radar based on the prevalence of the disease burden in those communities and the opportunity to use clinical guidelines and follow standards of care based on the evidence base that if we did that, we would in fact improve health outcomes. And so we had a roadmap, in essence. We have clinical guidelines that we can follow, and if our clinicians work together, learn those guidelines, develop mechanisms to make sure that they're following them closely, we actually also develop performance measures or quality measures or outcome measures to see if, in fact, by following those guidelines, we've actually improved outcomes, and we have. So the way that starts then is by understanding that there's an opportunity to improve care if we follow guidelines, and then testing different models and different approaches to doing that consistently and carefully, and then measuring the outcomes that result. So I think the challenge here, I think we've talked about here at this table, is simply this question of the evidence base and being able to articulate exactly what those steps would be that clinicians would take that would improve health outcomes. Would need to be the map that we could follow, but we would need that map in order to even begin to have that conversation.
Nancy?
So I know that in the last meeting we discussed this at some length, and that we advised the Secretary. Yesterday, I expressed a little frustration that for the amount of time we talk about guidelines, we could have written them already. So and we talked about, is there a possibility that we could develop some way to put these guidelines together to help you and HHS get them out there. If there's some way we could do this with HRSA's involvement, I think that as a committee we should recommend it needs to be done, and as an expert group on the committee, I for one would recommend to be a part of that process.
I'll comment briefly. HRSA does participate in the development of evidence-based guidelines, PHS guidelines in particular with regard to HIV/AIDS, partly because we have resident experts within the agency and have experience in managing those particular patients. Of course, that's a legislated program, and we have a specific focus. In general, we don't have a disease focus at the agency, and so you'd have to really look at the way that evidence-based guidelines are developed for all of the many other diseases that there are, and see where there would be a specific role for HRSA. I'm not quite clear about that yet, but it is something to think about.
Diabetes guidelines or hypertension guidelines. Why couldn't we also introduce into the training program of HRSA professional healthcare providers
Yes, the
a
guideline
advocacy
committees,
guideline.
the guideline committees for many of those programs are not housed at HRSA per se. They're at NIH and with professional